Swayam Prabha. Digital India. Educated India.
One of the key areas in medical genetics is dysmorphology. When we say some kid or some baby has a syndrome, what we really mean is the morphology or the appearance is altered. That is why we say dysmorphic. So, I will discuss how clinically we approach a dysmorphic child in the clinic as a clinical geneticist or as a physician. What is dysmorphism? This definition of dysmorphism or the term is coined by Dr. David Smith, who is one of the pioneers in the 1960s. He said structural defects, especially congenital malformations, are called dysmorphism or deviation from the normal, which usually indicates a disharmonic growth. Something grows extra or something grows less or something is not grown, that is the meaning of dysmorphism. They look little different. So, before we understand what is dysmorphism, we need to know what is normal. We have the world has several races, several ethnicity, people have different heights, different color, different skin color, different color of iris. We dress differently, but we need to know what is normal and what is abnormal. You can see a banana fruit here, which looks too big for it to be normal. So, what we need to understand before we define what is dysmorphism or what is probably not normal or probably what is a deviation from normal is to understand what is normal. It is defined in different ways or probably it is very difficult to define here, but statistically something which falls within 2 standard deviations from the mean on either side is considered as normal. Okay. So, if you take head circumference, height, weight, anything beyond 2 standard deviation, either less or more is probably not normal, or something within that within 2 standard deviation is considered normal for statistical purposes. If you take any measurement of any body part, you can have nomograms or charts to say what is normal, what is 5th centile, what is 50th centile and 95th centile. So, we have charts available for all the almost all the organs, and we have charts for specific conditions like Down syndrome, achondroplasia, and we compare and see what is normal and abnormal. But it is important to remember what is abnormal will look abnormal as soon as you see. Okay. But if you see any feature, any characteristic, definition wise it is 2 standard deviation. So, most of us are normal and we have normal body parts, but some things may vary from person to person. This is seen in about 4% or sometimes even little higher. Somebody's nose may be longer, somebody's ears may be smaller, or palms may have extra creases. These are very common and they are still normal. Minor anomaly, I will define it later, occurs in lot of people. It is seen in less than 4% of people, and there is no strict definition of what is minor anomaly, what is normal variant, or what is a major anomaly, but still we have some things to discuss here. See, you can see 6 ears, they all are normal, they all look different. There is no ear which looks similar to the other. We have hypertelorism, we use simian crease, clinodactyly. These are probably normal variations, but I will tell you sometimes they give important clues for presence of a syndrome, but they in isolation should be considered as normal variations. If somebody wants to read what is normal and what is abnormal, or what is the definition of abnormalities, I would refer you to this beautiful series of papers called Elements of Morphology Standard Terminology published in American Journal of Medical Genetics Part A. As a series, these several words like hypertelorism, telecanthus, clinodactyly, all these are defined, and all journals, all publications mandate all the writers or authors follow these guidelines for uniform description of dysmorphic features. What is a major anomaly? Major anomaly is some malformations or anomaly which has major medical or social consequence. It may be cosmetic or it can be functional, seen in 2 to 3% of live born children, as we see here in a neural tube defect. Minor anomaly, you can see an ear pit, a small cleft lip or a preauricular tag, which are relatively very frequent in general population, no significant health or social burdens, not even major cosmetic burden, but they warrant us to search for other anomalies and often permit specific diagnosis. I will give few illustrations, and several newborn babies have one or more minor anomalies. We use several terms in when we describe the anomalies or birth defects or dysmorphism. It can be a malformation, deformation, disruption or dysplasia, and these can be isolated, confined to a single system, or it can be a sequence where one defect or one birth defect leads to the other, or it can be causally related constellation of several features. We also use terms like syndrome or association. I will discuss these things soon. So, if you see this kid has an embryonic defect in the upper lip and palate due to failure of fusion of several embryonic parts, confined only to the lip and palate. This is called cleft lip and palate. This is a very common malformation, usually confined to a single system. We call it isolated malformation or non-syndromic malformation when it is only one organ or one tissue which is affected, as you see here, syndactyly. Okay. So, malformation refers to defect of an organ or a larger region resulting from an intrinsically abnormal developmental process. This is very critical to understand this. The developmental process is intrinsically abnormal. There is a defect, it cannot grow normal. So, it either will be either cleft lip, cleft palate or congenital heart defect or syndactyly. These are all malformations as we see here, and it is intrinsically abnormal as compared to the deformation or disruption which are the consequences of some abnormal external process, and intrinsically the developmental process is normal. Malformation sequence refers to a sequence of anomalies that result from a primary anomaly, which is a malformation. So, here we have a neural tube defect which is a malformation in this kid, and you can see flaccid lower limbs, overlapping digits, and anal sphincter. You can see here there is no tone or patulous anus, which are all sequences or effects of a basic primary malformation which is neural tube defect. So, this is called a malformation sequence. To define a sequence, it is a pattern of multiple anomalies derived from a single known or presumed anomaly or a mechanical factor. It can be a malformation sequence, it can be a deformation sequence, or it can be a disruption sequence. When we say malformation syndrome, this consists of several anomalies or several malformations, like you see polydactyly both in hands and feet, obesity, intellectual disability, and even pigmented retinal changes in the form of Bardet-Biedl syndrome. You can see here, this is a malformation syndrome, obesity, intellectual disability and polydactyly, several features together which are causally related. Syndrome refers to a causally related set of anomalies. Here you can see Holt-Oram syndrome, where you can see radial ray defect and a cardiac defect which are causally related due to a mutation in a particular gene. This is a malformation syndrome and you have multiple malformations. Whereas association, as we see in vectoral, vertebral defects, anal atresia, cardiac defects, tracheoesophageal fistula, this is an acronym for vectoral or ear anomalies, renal anomalies and limb anomalies. These are called association. A syndrome is a pattern of multiple anomalies thought to be pathogenetically related, and it is not a sequence. Whereas, an association is a non-random occurrence in two or more individuals of multiple idiopathic anomalies. We do not know the cause and we feel it is we do not find any relation between two anomalies, but they occur frequently. Once we had an acronym like charge syndrome, choanal atresia, heart defects and so on. Now, we have identified the genetic cause and the gene, and now we call it a syndrome. So, once we know the cause, it becomes a syndrome. If you do not know the cause, but it is a recurrent pattern of anomalies, we call it association. Deformation refers to anomaly which results from an extrinsic non-disruptive mechanical force. Any abnormal form or position of a body, you can see here the limbs are in abnormal form, there is a club feet bilaterally, which is probably because of lack of amniotic fluid, and because of the extrinsic pressure from the uterus you have this kind of anomaly, and this is not intrinsic, means the leg or the feet had a normal potential to develop normally into normal structure, but because of extrinsic pressure this has happened. Whereas, disruption is usually a severe mechanical force which results in breakdown or an interference with originally normal developmental process, as we see here because of amniotic bands. This is called disruption. The limb is amputated because some amniotic band has prevented, because of extrinsic or mechanical pressure, the growth of hands. Whereas, dysplasia is it is usually a histopathological term. It means an abnormal organization of cells into the tissue in different parts of the body. Usually the histology is abnormal. It can be skeletal dysplasia, where you see epiphyseal changes throughout all long bones. The epiphysis in humerus, radius, ulna, tibia, femur, all are abnormal. We call epiphyseal dysplasia, which is one of the types of skeletal dysplasia. Or it can be a defective ectoderm. You see lack of eyebrows, eyelashes and abnormal teeth, or even nail, which refers to ectodermal dysplasia. To summarize, birth defects occurs in a small percentage of population, around 2 to 3% of the population, which can be only confined to single system, or it can be a syndrome which are causally related constellation of several anomalies, or it can be complex and association. Their cause is often not known. It can be a teratogenic exposure in the intrauterine life, it can be a chromosomal anomaly, as we see Down syndrome, trisomy 21, or Edwards syndrome, Patau syndrome or Turner syndrome, or it can be a monogenic cause like Cornelia de Lange syndrome or Bardet-Biedl syndrome. So, it can be genetic, which can be monogenic or chromosomal, or it can be teratogenic or environmental, or sometimes we do not know the cause. How do we make a diagnosis when we see them in the clinic? It is like any other clinical case or a condition where we take history, we take family history specifically to see if other members are affected. We do a thorough examination from head to toe. Special investigations may be required. It can be an echocardiogram, it can be few X-rays, it can be a chromosomal testing, or it can be sequencing of one or several genes to identify the particular condition, and then interpret the patient's anomalies from the viewpoint of a developmental anatomy, whether it is a malformation, deformation, disruption, whether it is a syndrome or sequence or association. Categorize the nature of anomaly. I will show you in my next slide that nature of problem is usually characterized. Once you see them, you analyze what is the likely cause of the condition. It can be a malformation where it is poor formation of the tissue, deformation which means unusual forces on normal tissue, disruption which means breakdown of normal tissue, dysplasia means abnormal organization of the cells into the tissue. It can be single localized defects, or it can be multiple localized defect, which can be syndrome when they are causally related, or it is just random occurrence of a set of anomalies in which is called association. And there can be a sequence which happen, which are sequence of events which due to primary malformation, deformation or disruption. Once we know which system is affected, after we classify them into whether it is deformation, malformation or disruption or dysplasia even, then we can see if it is only affecting bone, it can be a skeletal dysplasia, or sometimes we have something like low birth weight, syndromes of primordial short stature or overgrowth syndromes, or large thumb as you see in Rubinstein-Taybi, that may be one of the major feature of a particular condition, or it can be similarity to well known conditions like Morquio like condition, Angelman like condition. So, we can categorize them like that, or group of conditions where craniosynostosis is a common feature, which are due to FGFR mutations, or mutations in one pathway, RAS MAP kinase pathway, which can lead to Noonan syndrome, Costello syndrome and cardiofaciocutaneous syndrome. This is how we categorize. Sometimes we need to approach in a different way. For example, if a child has dysmorphic features and has obesity, then we look into syndromes with obesity like Prader-Willi syndrome, Bardet-Biedl syndrome, Cohen syndrome and Alstrom syndrome. And there are several syndromes with primordial short stature. So, ask the birth weight, birth length and head circumference, which may be abnormal in Noonan syndrome, Williams syndrome, Silver-Russell syndrome, Rubinstein-Taybi, Seckel syndrome, DeLange syndrome, Bloom syndrome and Arscough syndrome. We need to slowly develop skills to categorize them into a particular group and then make a diagnosis, and it is not easy. It is a gradual and slow learning process to identify these syndromes. Sometimes somebody with a tall stature can have this thumb sign, wrist sign or skin striae or arachnodactyly, which suggest Marfan syndrome. This diagnosis becomes easy. You do an echo, you test the eye and then you have the diagnosis. Some syndromes are named depending on the clinical features we see. It can be, you can see the neck here, there is a pit here and the child was deaf and then had an renal anomaly. We call it bronchio-otorenal syndrome. So, you can see the ear anomalies, deafness and branchial sinus and a renal anomaly. We call it bronchio-otorenal syndrome. We need to draw the pedigree well, because we can identify what is the mode of inheritance, probably the likely gene, and phenotype well, both clinical as well as radiographic. This is syn polydactyly, inherited in family due to HOXD13 mutation. Sometimes syndromes are labeled like acro. Acro means hands and callosal. Corpus callosum is absent here. You can see preaxial polydactyly plus absent corpus callosum, and you make a diagnosis of acrocallosal syndrome. Sometimes we have unique diagnostic features, like you can see here the ears are crumpled, not crumpled, I would say cauliflower like, or the thumb is proximally placed, which is called hitchhiker thumb, and this is these features suggest diagnosis of dystrophic dysplasia. You can see a girl here with short stature, polydactyly, nail hypoplasia and oral frenulae and skeletal changes. We have chondro, referring to cartilage, ectoderm, nail and the skin, chondroectodermal dysplasia or Ellis von Creveld syndrome. Sometimes it can be a radiological clue here. You can see the molar tooth sign, which suggests a diagnosis of Joubert syndrome, and sometimes it may be an abnormal breathing pattern in these children with Joubert syndrome, which gives you the clue for diagnosis. It can be radiological or it can be a breathing pattern in this child. Why should we have a diagnosis? These, many of them usually lead normal life. Some might have an anomaly or of heart or some other major organ system, which might require surgical correction, or even for a limb the club foot may be surgically corrected, and sometimes it is just minor variations which do not harm you. But why should we have a diagnosis? Many times parents, once they notice that their child is not normal or the child has some additional features, they might want to know what is the child's problem. They might run from doctor to doctor looking for a diagnosis, and if something is different, what does it mean for our baby? Does he or she require some treatment, or it can be left alone, whether it will harm him later, or what will happen for him when he grows old? Will it happen in his children or her children? Why did it happen? What is the cause? Parents want to know, and will it happen again? So, it is probably important to tell what it is, what it means, and what are the ways to prevent the complications, what are anticipatory guidances that can be done to improve the health of the child. So, establishing a diagnosis for the family and the child is very crucial to know what is the condition in the child, and stop uncertainty and unnecessary doctor shopping, or it ends the diagnostic odyssey if we have a correct reason why this has happened. Okay. To understand the needs of the child may have specific needs in terms of nutrition, surgical care, medical supervision, or growth monitoring, or some anticipatory care for disturbed vision or hearing, and stop endless tests and consultations, better care of the child. And for other family members, there may be implication in the form of the condition recurring again in the parents, or a family member who might be at risk of having the disease or passing it on to their own the next offspring. For a physician, it helps to decide appropriate investigations for confirmation, as well as appropriate clinical management, which tests should be done for which system, and how the child should be followed up. It is easy and it is better for the patient if the physician has a definitive diagnosis, and of course, anticipatory care depending on the problems that are present and that problems that are likely to develop, and to prevent complications. Sometimes it is useful for research to understand normal growth and development, or even morphogenesis in human beings. Many times we do not have a specific diagnosis for a child who has malformations. So, it is important to summarize observations, discuss possible diagnosis. It is important not to label if you are not very sure what is the diagnosis, because that diagnosis whichever is labeled is carried on to next physician or pediatrician or somebody else. So, there is a danger that some wrong diagnosis is carried on for several years. If you do not have a diagnosis, re-evaluate, re-investigate, and probably you can call them for subsequent review, maybe after 6 months or 1 year, and probably you may be wiser, or you might have known about the condition, and then you may be able to make a diagnosis. Partial counseling is often possible. That is what I mean by this is, we might know the mode of inheritance when you draw the pedigree, and then we might be able to tell what is the mode of inheritance, but these are not accurate if you do not have a definitive diagnosis. Take help, see the books, ask your colleagues and experts. Now there are web tools, the phase 2 gene tools or apps, you can take their help for making the diagnosis, but confirm it by a specific test. Consider research if you think this is something different, or this is something which is not known. Be sure the family understands everything you know or your diagnosis, and do not know. If you do not know the diagnosis, please tell them that I do not have a diagnosis, I would like to follow up, or probably I would refer to somebody else about their condition. So, family should know what you know and what you do not know. These are very important in management of children. Unnecessarily labeling with a wrong or a fashionable diagnosis does not help, probably it stigmatizes and causes more problems than help. We have excellent books or databases. You can see a London medical database, POSUM, the paper series of papers which I cited, and gene reviews or gene tests, where tests are and labs are listed for several genetic conditions, including the clinical features and managements in gene reviews, and online Mendelian inheritance in man is regularly updated online database of several genetic syndromes and conditions, and we have standard books like Smith's recognizable patterns of human malformations, diagnostic dysmorphology, which defines the terms human malformations and related disorders by Judith Hall and Roger Stevenson, and syndromes of the head and neck by Bob Gorlin and Raoul Hennecum and other people. These are good places to see about syndromes, and we now have a book by Judith Alanson called Management of Genetic Syndromes. So, these are the places where you can read further about genetic syndromes and human malformations, and how to make diagnosis of these individuals, and how to help them have a definitive diagnosis and have better medical care. Thank you.